Good evening, Professor.
Yes, sir. Secretary, sir, welcome.
Can we start? Roshni?
Yes, sir.
All
So, sir,
set?
it's 3. Yes. So,
Yeah.
sir, it's 3, 2, 1. Sir, we are live now.
Okay, thank you very much and good evening to all of you on behalf of the Tamil Nadu Ophthalmic Association. As the president of the Tamil Nadu Ophthalmic Association, I have the greatest pleasure of welcoming you for this 4th TNOA ARC PG Masterclass on glaucoma. As you all know, this theme for this year is Tamil Nadu Smiling and TNOA Shining, and we're doing exactly that. We have become very vibrant in the past 4 months. So many webinars, so much of exchange of knowledge, so much of activities. And thanks to the entire team, which is behind me, executing this program to the grand success. This ARC PG Catalyst program, which is being powered by Milmet, I would like to thank them. We had the first one sometime in October, which was in optics and refraction by V.R. Vijayaraghavan, which was a huge success. The second one on cornea by none other than Dr. S.K. Rao, and which was again a grand success. A third one on cataract, which is on cataract and phaco and SICS by none other than Haripriya, which is again a very huge success. I'm sure today also we have got a fantastic master class here, and this master class is going to be done by none other than Satyan, who is going to be the course master for this. Along with him is our President-elect, Dr. Ramakrishnan, who is going to take this forward as well. And we have got a fantastic panelist in Dr. Murli Ariga, one of the leading glaucomatologists in the country and in the world as well. And very fortunate that he is part of TNOA and part of Chennai also. And of course, all these ARC programs are being done by our ARC chairman, the dynamic ARC chairman, most dynamic, I would say, a guy who has got multifaceted personality, none other than Dr. Rajshekar, who is spearheading these ARC programs very, very successfully. This is available on the YouTube as well as the Facebook, and for you, for all the delegates and postgraduates. This ARC programs is a PG masterclass, and we wanted to give a concept. For example, the first 40 minutes will be talked by, will be done by one speaker, and he will cover one basic topic, which will be useful not only for the residents and the postgraduates, but also for the practicing ophthalmologists as well. Then the second master, the second half will be covered by another master, which is first one is Dr. Ramakrishnan here, and then Dr. Satyan. And we'll have a good panel discussion also, and the entire thing will be moderated by Dr. Rajshekar. And with these few words, I also like to say that TNOA has got other activities also, the Walk the Talk program, which is again a huge success. On February 5th, we are having with Dr. R.V. Ramani of Shankara Group of Institutions. And of course, on January 30th, we are having the TNOA Connect series and cataract and IOLs with Rajan Eye Care. So with this, we are able to cover the entire, what you call the spectrum of super specialty, or what you call the subspecialty eye care, and which is not only beneficial to the ophthalmologists in Tamil Nadu, but all over the world, I would say. And we've got, every time the TNOA program is there, we've got a huge reach, and each of these webinars are being attended by about minimum of 2,000 to 2,500 delegates across the country. So very, very useful, very popular, and I have to thank all the stalwarts for making this a huge success. With these few words, I would like our President-elect, Dr. Ramakrishnan, to say a few words, and then followed by our Secretary, Dr. Madhavan. RK sir?
Respected President and Secretary, Dr. Madhavan, and ARC Chairman, Dr. My dear friend Rajasekhar, and the course director, Dr. Satyan, and my dear panelist, Murali, Dr. Ravishankar, and Rajasekhar, again. and also my dear delegates. Warm good evening to all of you. Wish you a belated New Year as well as a happy Pongal to all of you. As our president pointed out, Tamil Nadu Ophthalmic Association is doing a human service, I can say, in the field of academics for the past 4 months. Every month he is not left not even a single week without any academic activities. So in that also we have started this year a program with the New Year thing with Walk the Talk and other thing with Ramoti and other people. And of course, now today is a PG Masterclass. It's again on glaucoma. It's really it's a very nice thing that's this Pongal vacation, especially this Sunday. We can, I think it is a very good move forward to educate not only the postgraduates and also practicing ophthalmologists and other people in the field of ophthalmology. Definitely, it will be a very good boon, and also a discussion followed by the presentation will be definitely by the panelists will be definitely useful to all of us. Thank you, Dr.
Thank you, sir, the President-elect, for the inspiring words. Now our dynamic secretary, Dr. Madhavan, has been doing a really fantastic, I would call him the unsung hero, very humble, but very competent in whatever he does. Madhavan.
Thank you, sir. Thank you, sir. Dear President Dr. Mohan Rajan, sir, our President-elect, Dr. R.K., sir, Course Master, Dr. Satyan, and our dynamic ARC Chairman, Dr. Rajsekhar, who is not only involved in ARC activities, but also in academics, also involved in COVID cares, activities also. And we have Dr. Murli Ariga and Dr. Ravi Shankar, and the PG students and members of Tnoa and also other associations who are tuned in today via Facebook and YouTube. A good evening to you all. Today, we have Tnoa ARC PG Catalyst Masterclass in Glaucoma, and we have giants in glaucoma for this knowledge transfer. After all, knowledge indeed is power. Our congratulations to the winners of Tnoa National New Year Quiz 2022. We had Dr. Aparna, Dr. Rishabh Desai, and Dr. Sudan, the winners of the competition held on 1st January. And thanks also are due to our quiz master, Dr. Chandrasekhar. In the same vein, in the surgical strike initiative of Tnoa, Ophthalmic Video League, congratulations to Dr. Prasanna Venkatesh from Trichy for his presentation, which had a take-home message: surgery isn't over till it is over. So thank you, and we look forward to a master class from our masters. Thank you, sir. Thank you.
Thank you, Dr. Madhavan, for the nice words. And without much ado, I think we should hand over the proceedings to our moderator, Dr. Rajsekhar, Chairman of the ARC, to take it forward.
Vanakkam, sir. Vanakkam, and Pongal Valthukal to all. In fact, I should be very grateful to the President, because this idea of an ARC masterclass had become a brand, sir. The first time the flyer comes out, I just push it around to senior teachers all around Tamil Nadu and neighboring states, and ask them to relay it to their PGs. And every time I do that, I get some cute responses. And this time the response was, "Enapa glaucoma pongalakite," appadinu. That was the first response. And more so about the topics which our course master instructor has brought in, the million cells, about which Dr. P. Satyan is going to enlighten about, and of course the the attention catcher is the partial thickness filter of none other than Dr. R.K. sir, and I am sure that amongst with all our postgraduates and young ophthalmologists who are listening to us in all forms of social media and engaging with us on their chat boxes, they can type their queries on the chat boxes, and we are sure we are going to relay them and voice them to the instructors for their inputs. And I am also like very privileged to have Dr. Murali Ariga, who himself is one of the most sought after teachers in glaucoma, and Dr. Ravi Shankar, my close friend, Dr. Ravi Shankar, to do the moderating with me. And we sincerely believe that this session is going to be still more huge success than the previous ARC sessions, and set the tab higher for this ARC masterclass. Now over to Dr. Ramakrishnan sir, our Vice President and one of the most senior glaucomatologists in Tamil Nadu today, about the partial thickness filter. Over to you, sir.
Thank you.
Sir, 1 minute, sir. Before that, I would like to acknowledge the efforts taken by Dr. Ravi Shankar, who is with me at Rajan Eye Care, who is my right hand, left hand, center. Everything is, as you all know. And Ravi Shankar is the one who is actually gives me some ideas and makes me to do some lateral thinking. And the walk the talk, masterclass, all these are some of the inputs which Dr. Ravi Shankar has given me. And I'm very grateful to Ravi for that. Thanks, Ravi.
Yeah, definitely.
Thank you, sir. Over to RK, sir.
Thank you, Dr. Rajasir. Thank you, Dr. Mohan Rajan.
Yes, sir.
Yeah, I will share my screen. I think you have to stop your screen. I think, huh?
You can share your screen, sir.
Just,
You can share screen.
it's okay, huh?
Starting,
Yes,
sir.
sir.
Starting. Yeah.
Yes, sir.
Now go to first slide and slideshow, sir. Yes, sir.
Okay, it's visible.
Yes, sir. 100%.
Oh, okay.
Yes.
Okay.
Thank you very much.
Thank you. Thank you. Good evening to all. 2 weeks back, our IRC chairman Rajasthar called me and told that, sir, we have a glaucoma master class and you have to be one of the panelists. Then I told him, yes, okay, we can have a very good, we can listen to all the speakers of our various glaucoma specialists and we can ask some questions. Then next day, our Satyan, the master of the today event, called me, sir, நீங்க தான் பேசணும் ஒரு topic. I told there are so many people to talk in glaucoma. I will just simply listen and ask some questions. No. So you should talk with me. And that's what he told. That's because of that, I don't know what revenge he has taken on me. I don't know, because he definitely knows that I will go to bed by 9 o'clock every day, 9:30. So I don't know, purposely or accidentally, he has put me as a second talk. But I requested him to be made as a first speaker. Thank you anyway. Thank you, Dr. Satyan. Definitely, I think it will be one of the best master class.
Thank you, sir.
And,
Thank you. It's a wisdom talk.
my talk today is I was being asked to talk about the partial thickness filter. Because glaucoma, all of you know, is one of the common cause for the irreversible blindness all over the world. And management is still a challenging problem, even though there are so many options available. Still a challenging problem in the field of ophthalmology. And of course, it's the second leading cause of blindness in the world, and is expected to affect nearly about 111 million people worldwide in the year 2040. The unfortunate thing in this figure is nearly about 75% of the glaucoma are in the developing world. And of course, the 20% of the world glaucoma is in India. So you can imagine the magnitude of the problem of glaucoma in our own country. And the main therapy is mainly to protect, to prevent the damage to the optic nerve head in the form of cupping and defect, as well as preserving the visual function. This is the main aim of the treatment. And even though there are so many theories have been put forward for the pathogenesis of glaucoma, the only modifiable risk factor is intraocular pressure. So whatever treatment is administered is all centered around reduction in the intraocular pressure. And again, another important thing is glaucoma is not a single disease and it's a spectrum of disease. And similarly, there is no universal treatment that is applicable to all type of glaucoma. That also we have to keep it in mind. And there are various treatment options are available, like medical treatment in the form of drops, tablet, and syrup, etc. And of course, laser and incisional surgeries. It's there for quite long time. And also the other recent developments like non-penetrating filtering surgery, aqueous drainage devices, and minimally invasive glaucoma devices, and so many newer modalities of treatment are available to manage glaucoma. And of course, everybody was so much confused by the too many choices. So even medical management, we have now previously about 30, 40 years back, we had only pilocarpine, and later in 1982, we had only Tnoa with diamonds. And there is none other medication. Now we have so much of agents, pharmacological agents, lasers, and surgical procedures. So everybody is so much confused about the what treatment option we have to give it to the patient with a particular type of glaucoma. And of course, this is again another important thing, when to intervene in glaucoma. So many studies have shown that the earlier intervention has been proven to be effective in slowing down the disease progression. So you have to, suppose if you have a confirmed glaucoma with the typical optic nerve changes and the visual field defect with the intraocular pressure elevation, we have to intervene the patient either in the form of medical or laser or surgery as early as possible, so that we can prevent further progression and we can keep up the good vision and the quality of life of the patient. And this is a landmark study in the field of glaucoma. There's a collaborative initial glaucoma treatment study wherein they have compared the medical with the surgical treatment options. Here, the main outcome is the glaucomatous optic disc progression is higher in patients on medical treatment than the surgical patient. This is very quite obvious. So because the surgical patient, they had a very uniform, a sustained control of intraocular pressure when compared to the medical treatment where there will be a fluctuation in intraocular pressure. That's the reason why there is optic disc progression. And coming to the history of glaucoma filtering surgery, because all of the seniors, they will know it's a full thickness filtering surgery. It was there in the field of glaucoma for so many years, up to 1962. And the main popular full thickness filtering surgery is trephination. I'm very proud and happy to say this was first because most of the delegates are postgraduates. I will tell that this trephination was first done at our RIO GOH Egmore by Dr. Elliott. So it's called as the Elliott trephining. Then, of course, iodine glacis, wherein you incarcerate iris in the sclerocorneal wound, fourth iodine glacis, a single pillar, double pillar, so many modifications are there. Then, other commonly done full thickness filtering surgery is thermosclerostomy. So again, even I have seen our chief do this procedure when they joined the PGs. So such a, because even though intraocular pressure reduction is very, very good, it has got so many other disadvantages which will come to it later. Then because of that increased amount of complication with full thickness, they were constantly looking for some other alternative wherein you can prevent the excessive drainage so that we can have a guarded filtration procedure. Something to regulate the aqueous outflow from the antechamber to the subconjunctival field. There comes your partial thickness filtering surgery that's commonly done all over the world till now is the trabeculectomy. Then, of course, the recent advances like non-penetrating is still, it was very talk of the field for quite some time back, but now slowly it is coming down, the popularity of non-penetrating. Now, the glaucoma drainage devices, of course, the AGV, RD, and Barbells are there in the market, and with the minimally invasive glaucoma surgery, with so many options are available in the field of surgical management of glaucoma. This is just a timeline of glaucoma therapy, just to know the history. The pilocarpine there is till 1875 onwards. And at that time, the only in 1907, the first sclerectomy was the surgery of choice for glaucoma. Only by 1968, the modern trabeculectomy was popularized by Heinz, which will come to later. Then, of course, shunt in the 1972 and organ laser in between 1980 and 90, and of course, other things like AGV and SLT and minimally invasive glaucoma procedures, and similarly the pharmacological agents like prostaglandins and the other things like rock inhibitors can come to market in the recent years. And if you take the evolution, why this full thickness has not become popular? Because of the severe amount of complications, like excessive filtration, because nothing to prevent the flow of aqueous from the antechamber to the subconjunctival space. So they will have excessive filtration. As a result, the pressure will be very low, hypotonia-related complications, and of course, blood-related complications, cataract, choroid detachment, and of course, blood infections are very, very common with the full thickness filtering surgery. There comes, that's why they have come out with the partial thickness. But here it's a guarded filtration. The amount of hypotonia is very less when compared to full thickness, and of course, with the other things like infection also. But now, with the other modifications of trabeculectomy, especially with the use of antifibrotic agents to prevent wound scarring, and also with other adjunctive measures like laser suture lysis and releasable suture and so on, the success rate of trabeculectomy has tremendously increased when compared to the initial phase of trabeculectomy. And of course, this is a partial thickness filter is nothing but just wherein a partial thickness scleral flap is raised. This will create a fistula between antechamber to the subconjunctival space, thereby formation of a subconjunctival conjunctival filtering flap. So this is the why we are doing. We usually it's blood dependent surgery, not blood independent surgery. And of course, trabeculectomy with antimetabolites is the gold standard for surgical management of glaucoma till now all over the world. Initially, it was suggested by Dr. Sugar in 1961, called trabeculectomy with a guarded fistula, but it was later published by only Heinz, Dr. Heinz in 1968. After this publication, only the trabeculectomy has become so popular and was done all over the world. And of course, it provides a neat channel for aqueous outflow and most frequently performed this one. This is a very good market survey of anti-glaucoma procedures done in the States, even though it was done quite some time back, 1914. Still holds good because if you see the number of anti-glaucoma surgeries done, the filtering surgery, even though the number has come down, but it's not that fall. It's not that fall when compared to especially these are the tube sense is a little increase that especially Barbells and all other and etc. And another thing is the eye stent is again a little bit it's increased in the recent past, but trabeculectomy has its own role and role place. It still continues to be the most commonly performed anti-glaucoma surgery for glaucoma. That's why it still remains the gold standard. And this is just glaucoma continue. All of you would have seen the progression of glaucoma from a mild to severe form, but here It's a treatment option for each stage of disease. In the early stage, laser and of course drops, topical anti-glaucoma medication, and of course laser and mix in the early stage of glaucoma. And later on, we can go for blood-related surgery and other surgery glaucoma. Coming to the what are the indications for trabeculectomy? There are 4 definite indications. One is the failure of medical therapy. Suppose the medical therapy is inadequate to control the intraocular pressure, then we have to go for surgery. Then intolerance to medications because of systemic as well as ocular side effects. And in cases with the advanced disease, then 4th important thing is in spite of good control of intraocular pressure with the medication, still the disease is progressing. Then we have to reduce further with the anti-glaucoma surgery. These are the indications. And of course, the other relative indications are especially in countries like India, socio-economic condition plays a major important role because not all the people can afford to have use anti-glaucoma medication because of the cost factor. Then of course, inadequate control and the side effects, as I mentioned. Systemic contraindication. Suppose patient is having multiple systemic disease, cardiac, respiratory, some other renal disease, then we cannot continue anti-glaucoma medication for long, continue short anti-glaucoma medications. Then, of course, poor combinations, those who cannot use the drops regularly. And also when again, it's a deterioration is effect of medical treatment, then also we have to go for. These are the relative contraindications, blind eye, and of course, active inflammation, and active anti-segment neovascularization. And in cases where there is extensive conjunctival scarring, or thin sclera, or a chemical injury, a chemical trauma, and of course other conjunctival disease, pemphigus, pemphigoid, are all poor candidates for the glaucoma filtering surgery. You may ask why is such an invasive procedure like trabeculectomy still around after 50 years of this thing. This is a very good study wherein they have followed the case of trabeculectomy for 20 years. Here, if you see, there is a 90% survival of trabeculectomy success with the topical medication at the 20 years, and also 60%. This is again is a very big percentage wherein the survival without topical medication at the end of 20 years. Even you would have seen most of the seniors would have seen, even I have seen even 30 years back, I have done my trip, still working very well without any complications. And of course, the risk for failure is, as again mentioned, we take engage and all these things. And now there are so many other studies have come to compare the tube versus trabeculectomy study. Here, both the procedures were associated with similar intraocular pressure reduction after 3 years, but the complications were higher in the trap group, but most were transient and self-limited. That's one study. This is again another study wherein they have done primary tube versus primary trabeculectomy. Here also, the trabeculectomy with mitomycin achieved lower IOP when compared to the tube study. So this is again as another important question or thing that the postgraduates should know. What's the mechanism of aqueous drainage in trabeculectomy? There are several mechanisms have been put forth, and one is the transconjunctivally into the tear film, and second one is the direct absorption into subepithelial blood vessels and subconjunctival lymphatics, and of course content of the Schlemm's canal. We'll come to it later, and of course the endothelial channels of cut capillaries, and also whenever you do trabeculectomy, without your knowledge, inadvertent cyclodialysis, you are likely to separate ciliary body with the ciliary spur, small cyclodialysis cleft also. This thing. What are the features of a successful filtering blood? Of course, it's the quiet, like moderately elevated, not localized elevated, moderately elevated, diffuse with like microcytic changes. Relatively, previously we used to say avascular blood, but now it's relatively avascular and with good control of intraocular pressure. These are the features of a good successful filtering blood. And many studies are, many of you may wonder why is a procedure which carries a lot of risk like failure, wound leak, and blood-related problems, and of course hypotony, cataract, infection, and of course wipeout. Why people are still doing this procedure? Because, and also they are saying it's a gold standard, because most of the problem, most of these complications can be avoided by a good preoperative planning, and also during surgery, a modification of the surgical procedure depending upon the case, and also the main thing is the appropriate post-operative management, because glaucoma filtering surgery, trabeculectomy, doing surgery is only 50%, but the success depends upon the rest of 50%, how you manage post-operatively. That's very, very important. And also frequent follow-up in the first 2 to 3 months, very, very important to make it a success. And the points to be remembered during surgery is the local anesthesia with adrenaline, better to avoid adrenaline higher doses because it may compromise the circulation, ocular blood flow, and also repeat block should be avoided, and also continuous massage, continuous pressure, especially with the super pingy or corner balloon is avoided. You can give a gentle digital intermittent massage so that you can have a good soft eye during surgery. And to enhance the outcome of this one, a good anesthesia is very important. And of course, the patient should be comfortable in the table without any pain or anything. And of course, you have to have a soft eye and a topical steroid preoperatively if needed, and topical copies use of topical steroid postoperatively is very, very important. And of course, medical handling and minimal bleeding, thin scleral flap with the minimum overlay is very, very important. And then, of course, judicious use of antimetabolite and timely organ laser suture lysis or releasable suture release or massage is very, very important to make the blood to work. And also, this is a practical point where I want to tell all the people, you see, because for patient, every surgery is a cataract surgery. They may expect the good vision and everything. So we have to give a very good intensive counseling to the patient, because they will have an unrealistic expectation. They may think that they can get a good vision with after surgery and all these things. Of course, they will definitely have reduction in visual acuity in the first 1 or 2 months following tuberculosis. That also we have to tell them. So by thorough counseling, and also they should know what to expect. We should not advise, patients should ask for the surgery. And also, mainly we have to tell them not to improve their visual acuity, but to preserve the existing vision and the further loss of the visual function. And how to prepare for trabeculectomy, preoperative preparation is equally important. Suppose the patient is on long-term anti-glaucoma medication, we have to stop them for a week or 5 days, depending upon the duration of anti-glaucoma medication, and to start topical steroid for minimum for 5 to 7 days. Usually FML or dexamethasone 4 times daily for 5 days, but what we do, and this definitely will help to change the congenital cytology and decrease the inflammatory cells, improve the fibroblast proliferation, the goblet cells, and it will help to this one. And also, suppose the patient is on anti-platelet treatment like aspirin or warfarin, we have to stop them with the advice from the treating cardiologist or physician. And also systemic hypertension. Patient should have a normal blood pressure during surgery, otherwise we will have a bleeding, and which is very difficult sometimes to control. Then of course, preoperative, as I mentioned, especially in inflammatory glaucoma and in acute congestive glaucoma, and those who are on chronic medication, we have to give them preoperative steroids so that you can have a very good post-operative. This is what a study done to find out the success of trabeculectomy with the preoperative steroids. Very good success, 80% versus 50% without topical steroid. We normally give preoperative steroids, and suppose if the patient is on anti-glaucoma medication for a long time. And surgical technique, of course, a good anesthesia is very, very important. And of course, adequate hemostasis and gentle handling is very important. Anesthesia, this wider technique is available commonly. Previously, we used to do deductible bar and peripheral bar, but most of the surgeries, what we do at present is with sub-Tenon's anesthesia. Very rarely, we suppose the patient is very apprehensive about the block and everything. If they ask, if they are very cooperative, we'll go for topical with the intracameral anesthesia. And of course, the key surgical steps, because each and every step is very, very important for the successful success of the surgery, especially congenital flap and the scleral flap fashioning and paracentesis, and of course, all other steps. And exposure is mainly by a speculum, and of course, the corneal traction suture is preferred by many people, but normally what we do is the superior rectus periodal suture with the 4 cell. This will give you a good exposure, but some studies say that compared to results with the corneal traction with superior rectus, corneal traction suture will have a better outcome when compared to superior rectus periodal suture. And the conjunctival section is usually it was started with limbal based conjunctival section, and of course 10 millimeter from the limbus. We have to be very careful about the insertion of the superior rectus at the 7.7 millimeter from the limbus, and also you should be handled with extreme care and try to avoid buttonholing or tear of the conjunctiva. Use non-tooth person. Then of course fornix based conjunctival flap is again is recent popularized in the year 1982 in glaucoma because it provides a better and easier exposure and more diffuse thing. The other important advantage of fornix base is the blub. The blub will be very diffuse and very slightly elevated. And another added advantage is less time consuming when compared to limbal based flap. And also one thing we have to keep in mind is you have to do a watertight conjunctival closure. It's very, very important. Otherwise, you will have a wound leak. And these are some of the important differences between limbal based flap and fornix based flap. As I mentioned, it's time consuming limbal based and easy and faster in the fornix based. But main thing as far as glaucoma is the one thing is the blub morphology. In limbal base, we will have a localized elevated blub, but here the blub will be diffuse. Another important thing is the ring of steel, what we will come to it later, which is very common with limbal base and rare with the, you won't get in the cases with the fornix based flap. This is slightly shows this schematic diagram shows here, see fornix base. See, you can easily go much more posteriorly. You can have a very large area of aqueous drainage, and you can use antimetabolite posteriorly. But in limbal base, you see here you can use minimally. You can at the limbal site you can use, and beyond that, there is no exposure to antimetabolite. So here you will have a condensation of the fibrovascular band that will limit the drainage of aqueous or passage of aqueous humor from anterior to posterior. Thereby, you will have a localized filtering blub at the limbus. This is a ring of steel phenomena where you can see very well. See here, you have a limbal based flap. Here, if you see, the blub is localized avascular, but if you see surrounding the blub, there is a fibrovascular, dense fibrovascular band, which is adherent to the deeper scleral, episcleral and scleral structure, which will limit the drainage of aqueous humor from the blub to the posterior subscleral area. That's why the blub is so localized. And to avoid this, there's a Murphy's modified technique. They have done a fornix base and they have they undermined the conjunctiva and they have inserted mitomycin sponges much more posteriorly. And also the here also the scleral flap, we won't take the section will not up to the limbus and it will little stop 0.5 to 1 millimeter before the limbus so that you can have a posteriorly directed aqueous outflow. There's a Moorfield's modification. And of course, the management of Tnance capsule, thick Tnance capsule. Of course, the main thing is anti-metabolites, and if it is very thick in younger individual, better to be a partial nectar. And of course, coming to the anti-metabolites, it's the mainstay of glaucoma management, but it's mainly helps to prolong the blood survival and also to lower the intraocular pressure. Two commonly used anti-metabolites are one is mitomycin C, which is a powerful tool that needs to be used with caution. It's a double-edged weapon. You should be very, very careful, and you should be aware of all its long-term complications, and also you should be able to manage the complications also. This mitomycin is used in the form of a solution. I'm not going to detail about that. It's available in 2 milligram vial. Depending upon the concentration you need, you can 0.2 to 0.2 milligram, depending upon the indications. It's now hard and fast rule of thumb that we should use this amount of mitomycin not like that. We have to, depending upon the age of the patient, type of glaucoma, and duration of anti-glaucoma surgery or repeat surgery or secondary glaucoma, we have to tailor the dose of the anti-metabolite. And of course, the duration also similar to ranges from 1 to 5 minutes of exposure is very, very essential. And of course, how to use the mitomycin sponge, because we have to insert the mitomycin sponge much more posteriorly, not near the limbus, and also make sure that the free margin of the conjunctiva, what I did, you should not touch the conjunctival, mitomycin sponge, otherwise this area will not heal, and you will have a wound conjunctival retraction or leak, and all these things will be there. So that we should be very, very careful. Nowadays, we have started giving mitomycin injection also instead of mitomycin sponge. In selected cases, we use mitomycin injection in the dose of mainly 0.02%. That's 0.2 milligram per ml. That's 0.1 ml with 0.1 ml of 4% xylacane injected about 10 millimeter posterior to the limbus before starting surgery, and you just squeeze it and wait for some time, and then you start the surgery. This gives a very good result, especially the blood will so diffuse, and the blood-related complications and the immunity-related complications are very less in this technique. And then, of course, 5FU, previously we were using 5FU, but nowadays we are not using 5FU. Mainly now it started using only after needling of the blood we used to give. But 5FU can be used in glaucoma also in this, like a sponge. It's available as aqueous solutions. That's each ml contains 50 milligram. You have to choke with the sponge and then apply subconjunctivally. Or you can give the subconjunctival injection also. That's 5 milligram. That's a 0.1 ml of 5FU will contain 5 milligram of 5FU that you can inject into the subconjunctival space. Usually the scleral flap is usually 5 into 5 millimeter, and normally we used to take 4 to 5 millimeter this one. And the shape, the size, everything doesn't matter when it comes to the control of intraocular pressure. Whether you take a triangular, rectangular, rhomboid, or quadrangular flap, doesn't matter. But there are so many studies comparing the different shape and size of the scleral flap, that shows almost equal result. But normally we have from the beginning we are used to triangular scleral flap, so we used to take a triangular scleral flap, usually 4 into 4 size, and partial thickness 1/2 to 1/3 of the scleral thickness, depending upon the case. And also you have to extend the flap incision into 0.5 to 0.5 millimeter to clear cornea, and the flap should be of uniform thickness. Make sure that you have not done any buttonhole, and before that, you should have a very good scleral dissection. The sclera should not have any episcleral tissue or anything. You should have only sclera, so that you can have a very good scleral flap dissection. And of course, after taking a bed flap, then next step is the doing paracentesis. Paracentesis, I feel it's a very, very important step. It's a must in glaucoma splitting surgery, not only to reduce intraocular pressure, and later on also you can avoid complications. Doing surgery also you can avoid complications, especially sudden shadowing of the chamber, expulsive hemorrhage, or all these things can happen. So if you do a controlled decompression of the globe with the paracentesis, you can avoid all these complications. Especially we use 11 blade to do a paracentesis. This should be done while the globe is still firm before entering the anterior chamber. Then of course the next step is the trabeculectomy. Trabeculectomy, previously we used to use one-arm scissor, but nowadays people don't know how to use one-arm scissor. Mostly it is done by the Kelly's Desmond's membrane punch. And of course you should know this one-arm technique also is a very good technique which I used to do sometimes, not commonly, but previously I used to do most of my cases with one-arm. But now I started doing with the Kelly's punch. And when you do a trabeculectomy block, you should know what are the things you have to exercise. Mainly, not just one punch or two punch. This is what tissue you are removing is matter than the number of punches. One is you must have a portion of the sclera, the posterior lip, and then second is the Desmond's membrane, then the trabecular meshwork, then of course the other one is the portion of the Slem's canal in this area. So then only it is a complete trabeculectomy. Here I am doing with the one-arm scissor. You do your two parallel incision on either side and make sure that you leave 1 millimeter of scleral bed on either side to prevent excessive leakage from the side. So then after you enter the chamber with the knife, and then with the help of one-arm scissor, you just excise that portion of the block of tissue so that you can have a very good ostium, which will help to have a optimum drainage of aqueous humor from the anterior chamber to the subconjunctival space. This is how you can do it with one-arm scissor. But nowadays, the thing will become very easy with the Kelly's punch. And then, of course, you have to do a peripheral iodectomy. One thing you have to keep in mind is the base of the peripheral iodectomy should be a little bigger, larger than your ostium. Otherwise, the two pillar of iodectomy will come and herniate into the ostium and causes closure. And also, it will not allow aqueous to come out. That's why the base of the iodectomy should be little larger and it should be a triangular iodectomy. Then flap suture is, of course, you have to use a Tnoa nylon suture and 3 suture. There's one at the apex and 2 on either. Depends upon so many surgeons have their own way of suturing. But normally we used to do a superior releasable and 2 fixed suture on either side, and always bury the knot and also check the flow of the aqueous prevention of early post-surgical chamber. And also don't hesitate, to put additional flap suture if you are not able to form the chamber. That's the thing we have to keep it in mind. Conjunctival suturing is usually by vitral suture, absorbable suture, and it's non-reactive and biodegradable, and use fine tapered and non-cutting image. I think it's a limbal basis. The video is not working. This is a phonics-based flap. And here, as I mentioned, your watertight closure is very, very important. So that's why you have to pull this portion of the conjunctiva to the opposite side, so that you can have a very conjunctival ridge over the cornea. And of course, the 0.5 to 1 millimeter of the superior cornea should be covered with the conjunctiva. Then only once the heals, once the conjunctiva retract, it will not show up the scleral flap. That's how you have to do this suture. If necessary, you can put anchoring suture on the other side also. Suppose if it's very firm and there is no leak, then we can leave it with one suture on one side. That's a watertight closure is very, very important. Then at the end, we have to do a blood titration. it should be done very gently, very, very gently. If you use too much of fluid with the port, then all the sutures will give way. Then again, you have to open the wound and then repair it, or iris may prolapse into the ostium. So care should be taken when you titrate the wound. Then these are the important complication. That's a shallow chamber. That's why we are using this fixed suture, very tight fixed suture, so that you can avoid immediate post-operative shallow chamber. Then blood failure, to prevent blood failure, we are using anti-metabolites. Then I am not going to detail about all these things. Of course, releasable suture plays a major role nowadays. Suppose if you don't have a laser and laser, this is an effective alternative for the laser suture lysis, wherein you can put a tight releasable suture. Some people is 1 or 2 or 3, but normally one suture is more than enough at the apex. Some people will put 2 on side and 1 fixed suture 12 o'clock. This is this thing. But here the main thing, previously we used to take a bite from the cornea of 12 o'clock itself, so that the free margin will just moving over the superior cornea and you will have windshield keratopathy. Now that portion of the suture is intracorneal, so there will not be any irritation. Only a blind loop is over this area, which should not cause any irritation for the cornea. So patient will be comfortable with the releasable suture. But the disadvantages, another is especially it's very useful in thickened tenons tissue, wherein you cannot do laser suture lysis, and also, as I mentioned, if there is no laser, we can this one. And the post-operative medication, steroid is the mainstay. You have to minimum for 3 months. We used to in tapering doses, and also it helps in so many ways. And depends upon the post-operative behavior of the blood. We have to modify the dose of this one. And of course, cycloplegics, especially atropine or hometropine, a minimum for 2 to 4 weeks is very, very essential in all cases of glaucoma, whether it's angle closure or open angle. Any case, you have to give cycloplegics. Follow-up is a frequent follow-up is very, very important. The first 2 to 3 months, so that you can do whatever necessary to make the blood work, and digital massage, all these things. And to summarize, trabeculectomy is still commonly done gold standard surgical procedure because it's a wider indication. That's one of the added advantage of trabeculectomy, which is not with the other newer medical modality like mix and all the non-penetrating. They can only do for open and glaucoma only. But in any case of glaucoma, we can do this trabeculectomy. And also the surgeon should, as I mentioned, post-op care is very, very important. And of course, finally, a proper care selection, optimum of anti-metabolites and good surgical steps and proper post-op management will yield a long-term intraocular pressure control. Thank you very much for your patient hearing.
Superb, sir.
Superb, sir. Very thorough,
Thank
very
you.
extensive, and very
Thank you.
very, very.
It's a
Like,
true masterclass.
PGs can write a full question on trabeculectomy.
Thank you.
With just
Thank
this
you.
class, sir. Nothing else
Thank
they
you
need.
very
They
much.
don't even need to open up. Sir, few questions. We have got few questions. I'm sure the panelists will also join. Murali Ariga, sir, Satyan. Sir, in post, you said about stopping prostaglandins before surgery.
Yeah.
How long? One question, sir. How long? And in that intermediate period, what do you offset it with? That is the question.
Yeah, minimum prostaglandin we used to stop for 5 to 7 days, depending upon the duration, how long they are using preoperatively. And because this will help in so many ways, because prostaglandin as such is, it will produce subclinical inflammation. And also the main culprit is the congenital fibroblasts. The congenital fibroblast population will go up like anything with the prostaglandins and other pilocarpine and other things. And also the number of goblet cells will come down, which is also very much essential for the wound modulation. And also the subclinical breakdown of the blood aqueous barrier. That's also one of the things. So definitely this will stoppage of will help to improve the success rate of the everything surgery.
Any other panelists want to add a point, sir, to this question? Shall we go to the next?
I'm in awe of the talk which Dr. Rathi has delivered, and I think this is always a learning opportunity, and we are learning from him every day, all the time. How many ever times I watch him, I think there's always something new to learn. Amazing talk, sir. Fantastic talk.
Thank you. Thank you.
Just a few small clarifications.
Yeah.
Yes, sir. You mentioned about the pre-op assessment of the patient before trabeculectomy.
Yeah.
So, would you include conjunctival mobility, sir, so you know where you
definitely, definitely. That's very, very important because conjunctiva should be mobile, and suppose especially in cases where previous filter or any other endocataract surgery or any other thing where it will affect the conjunctival, that you have to. And also during surgery, also if necessary, we can give subconjunctival balloon. You can see area of adhesions.
Correct. In fact, I do that so routinely, so it's almost become like a habit. I raise.
Okay. There's nothing wrong in that.
Caesar used to teach us that, so we used to use a saline kind of.
Yeah.
So it elevates the bleb, and you start seeing how much it actually elevates before you.
That's correct. Yeah.
And also, I also would probably add that I sometimes do a gonioscopy carefully pre-op myself, not depend on other people's data. Look at, suppose there's extensive synechiae or neovascularization, you would probably avoid that particular site for doing the trabeculectomy.
Yes, a good point. Yeah, you can. Yeah.
And lastly, about the newer recent surgeons who are all doing clear cornea temporal phacos. So the superior conjunctiva is actually a pleasure because most glaucoma surgeons we now have to operate. So even the SACS is now being done temporally, so we do have the luxury of operating conjunctiva.
Yes.
What I usually suggest to people whom I teach is that I prefer to do the trabeculectomy superiorly itself, so that we avoid using the temporal conjunctivas, and suppose the trap doesn't work, we can probably go in for a tube temporally.
Superior temporal. Yeah.
So that is what I would like to add. So
yes, okay, super.
Citing the trabeculectomy, because the cataract is usually done temporal. So you can do the trap at 12 o'clock, and you leave the nasal and maybe the nasal for a retrap, and the temporal for a tube subsequently. So that option of going back and doing something is always there.
Super.
Yeah. And the traction suture also I would like to mention. So I think you really gave a very excellent method of showing the traction suture, both with the corneal traction suture as well as the superior rectus. I sometimes find the exposure can sometimes be adequate enough that you may not even need a traction suture. Actually do without a traction suture, so that avoids even the extra bite to the cornea. But that is of course not for the trainee. Trainee surgeon should have a good exposure and should not get perplexed with the sudden decrease in the field of the surgery. That's all, sir.
Okay, thank you. Thank you.
One another question, sir. Like if you have to do bilateral surgery, what is the spacing RK sir uses?
It's not like cataract. Here I will wait for some time, minimum of 1 month, 4 to 6 weeks. I will wait. I have to see how the blub works. Because it's not enough to say 6 weeks, but you can somehow anticipate whether it's going to work or not. So minimum, So not before that.
Yeah. Other panelists, sir? Ariga, sir?
I have a few questions.
The same, sir. I think I would definitely wait at least a month if given a choice.
Yeah.
You won't know what to expect, what is the height of the bleb, what is the pressure response, any modifications. You rush in and do the same mistake in both eyes, then you'll end up cutting a sorry figure. So better to give some time to analyze, assess the bleb, post-operative function of the bleb, and then manage the bleb carefully and give it at least a month. And usually we have enough time. There's no real need to do an emergency bilateral trabeculectomy for any patient. So I think we do have that much of time.
That's true.
So 6 weeks will be a good number.
4 to 6 weeks.
MR sir wanted to
I have a few questions for Dr. Ramakrishnan.
Yes,
and other panelists also. Fantastic talk, sir. I think it's very comprehensive and very, very useful and very informative as well. And step by step, it was a true masterclass, I would say. The first question is, how will you make sure that the iridectomy, you said, no, You don't want that base of the iridectomy to occlude the ostium. How will you make sure that your iridectomy is the correct one?
Yeah, it's a wonderful, wonderful question.
Because I've done
Yeah.
a lot of trabectomy.
Because you have to.
Sujata is doing a lot of trabectomy.
Yeah.
Yes.
Because the main point is, iridectomy should not be small. That's a thing, but theoretically, it should be little larger. The base of the iridectomy should be little larger than your ostium.
Ostium.
So that the ostium, that the iris will not herniate into the ostium and causing blockage.
I understand.
But you can do just with the help of iris forceps, you can just pull the base of the iris, but you should be very careful. You should not injure the major arterial circle also. So just you just pinch the iris, the bunch of iris, then you just cut the with the perpendicular to the other one with the Vanna scissor or Rebecca scissor, so that you can most of the time you can get a good iridectomy, a good iridectomy. Yeah.
The second question I want to ask you, sir.
Yes.
Limited with the iridectomy, sir.
Yes, sir. Yes,
It's better to err on the side of a larger iridectomy than a smaller one. So that you don't end up with very small micro
Yes. You're correct.
Yes, sir. This second question I want to ask you is that because I had a discussion with when Daljit Singh, I used to have when he came for a conference in Chennai also, and whenever I meet him, and he used to always tell, I think we are making a mistake. That's what the same words I'm Daljit Singh repeating.
Okay.
We are all making a mistake. I think cataract we can do anytime, but we should do more glaucoma surgeries than cataract surgeries.
Oh.
That's what he said.
Oh, okay.
Because glaucoma is a blinding disease. Cataract is not a blinding disease. Okay, looking back from what I think it's the words of wisdom, I would say. Why even glaucomatologists are hesitating to do the surgery? They are based on drugs, maximum drugs, and the drugs, they are. It's only favoring the drug companies, I would say. And the fluctuation, as you rightly said, the fluctuation, once it's high, once it's down, every time it's high, there's a micro damage to the optic nerve. We are not sure. And why even the glaucomatologists are not rushing into early surgery? Why? Because are they not confident of the results like cataract surgery? What is the reason?
No, that's a good question. But one thing, we have to be very here, because the patient is accord. As ophthalmology, we can say that we are lowering the intraocular pressure and the visual function is preserved. But the patient will not get any appreciable benefit out of our treatment, whether it's a medical as a surgery. And also the R factor, suppose you have done a phaco with foldable, next 1 hour, the patient can see entirely different vision. No? But here, the patient satisfaction is one thing. It's very, 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 it's not that great unless the patient is one-eyed. No, that's the reason. And also the level of skill of the surgeon, it also matters. Level of skill, and also that's why many of the general ophthalmologists are not doing glaucoma surgery routine. Yeah.
Sir, I have a question for you and Satyan and others also. That what would you consider as maximum medication? For example, I have people now using on to add Diamox as well, and keep, like Dr. Mohan Rajan was pointing out, that we do keep waiting with maximum medication, still wait longer than possible, and then finally do only a cataract and not do the glaucoma surgery. So what would you say is maximum, and when would you say now this is the limit I should operate?
This maximum medical treatment, when if there is two things. One is maximum medical treatment, and second is the maximum tolerated medical treatment. Now, previously we had only a limited option, like pilocarpine, timolol, Diamox, and epinephrine. That's a maximum. That's a theory I'm telling. But nowadays, you can give 4 or 5 drugs. But some people are even ready to use the drops. And your doctors are also not advising surgery. It's quite surprising why people, because it's not that easy to use 3 or 4 drops with so many frequencies. It's very, very, practically, it's very, very difficult. So in our practice, maximum 3 if necessary. Otherwise, we will advise them for surgery. I don't go for many drops. One fixed combination, another individual drug, that's all. If it is not controlled, then go for surgery. Yes.
3 medications, 2 bottles.
Yeah, that's all. Yeah, you're correct. Yes, yeah.
Only can I just add?
Yes, yes, I think.
RK sir, good evening, sir.
Good
Now,
evening.
I think you must be happy that why we had asked you to speak. Sir, it is more than 30 years of your experience. I would have preferred you without even slides, you would have spoken better. And
yeah.
can you hear me, please?
Yeah.
Satya.
I was saying that my mic is not on, so that's why. Okay. So coming back to this topic as such, we used to see the success rate is far better when we were giving only timolol and pilocarpine than what we are seeing now. So definitely not more than 2 in my preference. When I go out of country and operate, everybody is on at least 4 or 5 medications. And it is just a matter of 6 months or 1 year time for the blebs to go for a failure. So earlier you advise for the surgery, it is always better. And if you have seen hyperemia, especially after the prostaglandin usage or the newer medications usage, it is better we stop and then give the proper steroids and then take up for the surgery. You may have a better results than just going blindly for the trabeculectomy. But early trabeculectomy is definitely preferable. But I feel we haven't trained enough number of people. One part. The second part is, as the companies had come up with all the so many medications, all the junior colleagues are just taking up only the medications than going in for surgery, which is not a good sign to see. Of course, the medical companies will give all the informations about the medications and the advantages, but then we have to make sure that the surgical training goes in a much better way. That's my desire to do so. So that's my inputs for you, Murli.
Thank you, Satyan. Thank you.
I think we should
We have a couple of more questions from the PG side also, sir. One point they're asking is, RK sir has not mentioned Ologen anywhere.
Well, not.
Please, sir.
No, it's got limited. It has got limited indications, like where there is a sclera is very thin, like especially high myopia, and also in patients who had hypotony and hypotony maculopathy in one eye. In other eye, we can think of Ologen. But I am not a great fan of Ologen like Satyan. Satyan can give more.
Yes, sir. I have been using since 2007 onwards when it was introduced in Indian market. One
thing I am not using is the cost factor because it's not.
Yes, sir. Yes, sir.
Yeah.
No, I completely agree with you, sir. There is no denial on the cost factor. But with the insurance being there, I think there is a definite option that we can go in for it. So having said that, the Ologen, one thing what I'm seeing is never use Ologen with the mitomycin C. That is the one thing which I think. Whatever I have done in 2007 to 10, we have used mitomycin in few cases, especially the pediatric ones. But now I am seeing those patients after 10 years, I'm seeing those coming with the limbal area. You see that there is a nice thin avascular bleb. And just posterior to that, you can see that fibrosed area, which is the Ologen. So I wouldn't prefer to go for a combination of mitomycin with Ologen, because nowadays a lot of people are asking, can we use still the Ologen? But I mean mitomycin. But the mitomycin, you will not have any problems in the first 3 to 5 years time. Only after 5 years or 6 years, you start seeing the thin avascular cystic blebs or high blebs. So never try to use the combinations. Always go with a single one. And in Ologen, probably you can go for a 10 by 10 by 2 half cut. then going in for the 6x2. The 10x10x2 with the half cut is always gives a better option for the surgical success. Probably we can have that as a separate class as such, then going in for a detailed one now.
Just a quick point about Ologen. I have
Yes,
also
go
been
ahead.
using Ologen for quite some time, but for the last 2 years, I have completely stopped using Ologen for various reasons. One is that the Ologen one small bit costs about 8,000. Second main reason for stopping the Ologen was that my results with Ologen in one eye and mitomycin in the other eye with a relatively 0.2 for a minute or 0.2 for 2 minutes, I did find that there's hardly any difference in the surgical success of the blood between Ologen and mitomycin. And given the experience and the things we learned with using mitomycin, with such a low cost option getting similar, if not better results, so I think most of us have sort of moved away from Ologen, and now the availability also has become an issue. So I think almost we have all stopped using Ologen. I have stopped using
That's the correct answer. Yeah.
Good.
In a normal trabeculectomy, in a successful trabeculectomy, how frequently should we ask the patient to come for review? That's a question. In a successful trabeculectomy patient, how frequently he comes to review? Like
the post follow-up, I told in the first week, second week, fourth week, 6, 8, 12, and 6 months, then 1 year. Then after that, every 6 months or 1 year, depending upon every 6 months or 1 year.
Every 6 months. Every 6 months. Yes, sir. Yes. I think with this we come to an end to the partial thickness filter. We close down the partial thickness filter topic and now go to the million cells. Dr. Satyan, all you are. You'll have to tell us about the million cells and why you named the talk as million cells.
Satyan
all yes.
Satyan is a millionaire now.
That's why he chosen the topic. Satyan?
He's sharing the screen. Yes, Satyan.
Satyan, கேட்கல.
Mute. Please unmute yourself.
Sorry.
Yes.
Yes.
Thank you, President, sir. Thank you, ARC chairman and all others in the panel. Good evening to everybody. I'm not sure whether it is good evening or good night now itself. So, it's a kind of a dry topic, but let me see how I can make it a little bit at least more interesting. So when the light falls on the retina, the photoreceptors are getting activated, and then you can see the path goes via the cells, ganglion cells, and then the axons are formed by these ganglion cells, and then it goes into the brain, and then of course the process is happening there. This is how so what we are trying to talk about today is this the ganglion cell layer and its importance. So we know that we have kind of 1.2 million ganglion cells. And of course, we have about 18 different type of retinal ganglion cells. That's quite interesting to see what these functions are. Let me see why my slide. Okay. So you can see here, there are many different types of ganglion cells. So I'll just come to this here. Based on its anatomical classifications, or it could be molecular classification or functional reasons, the ganglion cells are modified into many ways. By looking at its soma, it can be small or large. By looking at its dendrites, then you have these different type of classifications. So there are at least major 3 different cells. One is the midget cells. Then you have a small bistratified RGCs. Then you have the parasol cells, and then I'll come back to that little later. So when you're looking at the midget cells, are called as P cells, or it projects into the parvocellular pathway, and mostly it is present in the central retina. Main thing is the function is more of a color perception. That is what the midget cells are meant for. Then coming to the parasol cells, are otherwise called as a M cells, that projects into the magnocellular pathway. It constitutes only about 10%. When you see the midget cells, it is about 70% of the RGCs are midget cells. So only the 10% of RGCs are the M cells. It represents a larger area or larger receptive field. So this is the important cells for us. And it looks at the higher sensitivity to the luminance, contrast, motion, flicker, and also the depth perception. Then you have the bistratified cells, which constitutes about 5 to 8% of the retinal ganglion cells, smaller in size, and it projects into the corneocellular pathway. It is responsible for a good color vision with a low spatial resolution. Then you have another interesting cells called as a melanopsin containing intrinsically photosensitive retinal ganglion cells, which helps in the circadian rhythm through the projection of projection into SE, and I'll just come back to that a little later. So the regulation of pupillary light reflex is done through this projection into the OPN. So when these cells are affected in the neuropathies, like these cells are affected in other neuropathies like a glaucoma or late onset neurodegenerative disorders like Alzheimer's and the Parkinson's disease. So you can see the representation of all these cells, the IP-RGC, the melanopsin containing cells, the RGCs representing into the olivary pretectal nucleus and also into the suprachiasmatic nucleus. That's what I was telling you earlier, the SCN, what is SCN means. The small bistratified cells where it is represented, midget cells, all these cells where it is represented into the lateral geniculate nucleus. So what are the problems of these million cells? It has its functional issues, or when you have the structural damages, how it really works. So looking at the functional part of the retinal ganglion cells, how do you really evaluate these functionalities? Is looking at the visual acuity testing, not by our regular Snell lens chart. It is with a spatial resolving capacity, that is the logma chart we have to see with this. And then you have the contrast sensitivity chart you can use to see that. You have the color vision test. Of course, it really helps us to identify whether the patient has a neurological disease or it is a glaucomatous disease. Of course, the visual fields, when you're doing I'm not sure whether how many of you know that the frequency doubling technique, which really focuses on the problem of the magnocellular pathway. And then you have the corneocellular pathway, which can be identified by doing the SWAP, that is short wavelength automated perimetry. Looking at the chromatic pupillometry, we can look at the IP-RGCs, that is what is been mentioned. Of course, now you have the functional test with the more objective functional test, the electrophysiological testing, especially on the diopsis, that is a pattern ERG, and also you can look at the photopic negative response waves to see how the ganglion cell function is. So looking at this magic machine, how this can help us identify the damaged the ganglion cell layers. So that is the magic machine. Of course, it has been used in every field, neuro-ophthalmology, cornea, cataract, glaucoma, neuro-ophthalmology, everywhere it has been used. So I'm going to talk mostly from the spectralis OCT, which I have. So I'm going to talk mostly from that. Of course, we can identify each layer in the spectralis OCT. Like you can see in the bottom of the screen, you have the retinal scan, the posterior pole examination. You have the retinal nerve fiber layer, ganglion cell layer, all the other layers. You can see the INL, OPL, and of course up to the RPE. So we are going to see how the importance is. So as I told you earlier, once the light hits the RPE, then goes into the rods and cones, and then goes to the bipolar or horizontal cells, goes to the ganglion cells, and then the ganglion cell axons forms the optic nerve. And then you know the pathway, it forms goes to the lateral geniculate nucleus and then goes to the visual cortex. So this is the pathway. So we all know this. So let's see the optic nerve. Of course, we know that the formation, and this is how all the layers are seen in the OCT picture. So what we are looking at is this minimum rim width. So I'm going to use this word minimum rim width very often in this, and also the let's look at this. So there is something called as the Brooks membrane opening, how it is important for us to understand this. So we all know that we have the Brooks membrane opening is here, and then we have the axons over there. That is a minimum rim width. And when you're looking at the optic disc, in clinically, we look at this as the scleral rim we identify as the disc. But the true disc is not that. When you're looking at only the Brooks membrane opening, that is the true disc, which I'm not going to describe in too much now. So we'll have that as a separate one. So this is just a brief I'm going to talk to you about here. So we can assess the true disc area by looking at the BMO area, that is called as a BMO area, Brooks membrane opening area. Based on that, we can say how the size of the disc is. So there's another concept called something called as a automated anatomic positioning system. Why it is important? We know that the axonal configuration in every patient, in every eye is little different. It can be varying between, say, from here, you can see this is the macula and this is the disc here, and you can see the macula is much down here. So the macula can be anywhere up here, somewhere around +2 degrees to -17 degrees lower. So that is the reason why we need to have two areas to be measured. One is the macular centration and another one is the disc centration. So this is how it has been done. So first is detection of the fovea, and then you have the detection of the, confirmation of the foveal centration, and then the machine detects the BMO area and then BMO confirmation. So these are the four things needs to be done to assess how the configuration of the retinal nerve fiber layer is represented in each patient. So this is essential to identify first. Then once the area is identified, then the machine scans the optic nerve area. So looking at the neuroretinal rim, how good it is. There are 48 points scanned and about 24 radial scans are taken over these 48 BMO areas. Then the machine also gives you the confocal IR imaging. This is important sometimes because when you're looking at the cup area, some patients we may be confused, is it a glaucomatous or is it a non-glaucomatous? So this really helps us in identifying. So in this particular machine, the spectralist gives you something called as a software called as a Glaucoma module premium edition. So this is the fundus photograph. And you can see how this machine takes over that. So this disc area is covered like this, and then you have the posterior pole is covered next. So this is how the machine takes all the pictures. And then we read out the one is the optic nerve radial scan. And then you have the posterior pole horizontal scan, and you have the posterior pole vertical scan, which is not really very useful, but in some cases it may be very useful. But these two are the important scans that one has to understand. Coming to this, we have to go systematically when you're looking at these scans or CT scans. First look at the rim, then you go to the retinal nerve fiber layer area, then you have the ganglion cell layer. These are the three areas you must concentrate in every given patient, but just don't jump into the GCL and then come to some conclusion. It should never do that. Then something called as the minimum rim width. So I will not go into the details. There is a reason why we have to go for a minimum rim width. This is the axonal bundle here. When we are looking at this, then we can understand how much of the damage the patient has. Then going in for a horizontal rim width. That's going to be again another theory class, larger theory class. We'll have the discussion time. We'll discuss that. So never see only this scan. Most of us have the habit of seeing the numbers here and then trying to understand what is going on, but that is not the true case. Always look at the graph and see which area the dip is happening. This is actually, it is a generalized numbers. It is a averaging out. So don't look at the average numbers here, but of course it can give you some importance, like 1% probability, or 5% is in yellow, and then you have the green is in if it is like 5% or more. But that's not enough just to look at this, but we have to look at this graph to identify where exactly is the damage happening. And then we need to identify which disc is bigger in size and which disc is smaller in size. You can see here, it is about 3.4 mm of the BMO area. That means the disc is really big, and this is about 1.9, so the disc is relatively small. Just to give you a perspective of this, when you say a macropapillae, you can see the axons are a larger area, so the thickness is lesser. And you see this is a smaller papillae, so all the axonal bundles has to be accommodated within this smaller area. So you will have a large, I mean, what you can say is the number wise, when you're looking at the MRW or the minimum rim width, you will have the higher numbers like 150, 145, something like that. When you're looking at the micropapillae, then the numbers will be like 110, 112, something like that, depending upon the size. So this is what I'm saying. This is the line where it is given here in the graph itself. Anything above this will be in the micropapillae. The thickness is more, and the thickness will be less in a macropapillae. Larger in size, thickness will be little less. So retinal nerve fiber layer thickness, next comes the retinal nerve fiber layer thickness. In the spectralis, you have 3 lines here. You can see that there are 3 zones, 3.5, 4.1, and 4.5. The reason is when you have a larger the disc, the one which is like 3.5 mm area may not give you the enough of the details. So we can go for a 4.1 or 4.5 to understand how the retinal nerve fiber layer thickness is going on in those areas. So that's how we look at it. And again, don't see the numbers, always see where the dip is happening, the inferior temporal area, how much is the dip is happening and which area it is happening. You can easily identify and go for it. So the next important area is the posterior pole horizontal scan. So you know that this is how the posterior pole horizontal scan is done in the spectralis OCT. It scans and then gives you the GCL and all other 10 layers of the retinal map. And then you can, so this is the map from each layer, like a retina and RNFL, everything. So I will just discuss this. And you can see here, see this is the posterior pole map. You can see this is the whole retinal thickness. You can see that 300 plus is the numbers. And you see here 200, it has come down to 270 or 286. So this is what happens in the glaucoma. This is how you see the full retinal thickness will be around 300, 270 to 350, something like that. Then you can see the asymmetry between the upper part and the lower part. In glaucoma, usually it is asymmetric representation will be there. When there is a damage happening, it is always asymmetrical. You can see this is the ganglion cell layer analysis. You can see that the ganglion cell is between 40 to 60 or 55 is the thickness. You can see once the thickness has come down dramatically, here it is 16 and 12, and you see here it is 47, 50 and 56, something like that. So this is like a snail pattern. The snail can be the superior or inferior snail pattern. Then you have the retinal nerve fiber layer analysis. You can see the bottom here. The inferior RNFL is completely gone, showing that completely a zone of not seen. The red is the thickness, higher the thickness, white is even more thicker. So it is completely washed away here. And this is the deviation maps. So this is the actual map, and this is how much is the deviation from that. And this is the retinal nerve fiber layer, and you have the ganglion cell layer also. You can so the previous one is the ganglion cell layer deviation, and this is the next one is called the RNFL changes. What is happening here? How do you really see in glaucoma metastasis? This is how you see. You can see the RNFL is completely not seen over here, and this is the representation of a total retinal thickness and the GCL in the normal eyes, how it will be. So we have to just go and see how the GCL appearance is in glaucoma. Typically, you have this kind of a pattern. Either it is superior half is damaged or inferior is damaged, depending upon where the RNFL is damaged. So this is the GCL map. You can see the snail pattern. It can be inverted also in some patients. So it can be completely lost also, depending upon the amount of damage the patient has. So this is the overall glaucoma overview of the thing. This is the minimum rim width area. Usually we have the damage which is occurring in the inferior temporal zone or the superior temporal area where the retinal nerve fiber layer is damaged. In this case, you can see the inferior area is damaged, which is correspondingly, you can see the damage here. This is the typical of glaucomatous damage. So you can see from the posterior pole, the GCL thickness, the GCL deviation map, RNFL thickness map, and the RNFL deviation map. So with this, we can say, we can compare it with your visual fields and understand how much is the damage going on. This is the one is the structural test and another one is the functional test. But this is how the normal GCL will appear. This is like a donut pattern. You have the central hole, surrounding is the GCL. This is a typical donut pattern in the normal GCL. And when you see the early glaucomatous eyes, you can see some defects are happening in the lower part. You can see the RNFL is getting damaged. And this donut is open. This donut is again open. And coming to the moderate glaucoma, you can see the donut is completely broken in the inferior part. Here again inferior, again one more inferior area. It depends upon the RNFL damage. When you have advanced glaucoma, this is how you see the GCL is almost completely lost. You don't see any more GCL here. So this is the typical glaucomatous eyes. But then when you have, look at all the information, before that, don't try to come to any kind of a conclusions. So look at the fundus photograph, look at the GCL pattern, look at the RNFL pattern, and look at the visual field damage, how it is happening. You have to correlate. It is just not that you have one OCT taken and then trying to say that, okay, patient has glaucoma and then you start treatment. There is no way you can do that. It could be the vascular occlusions like a branch retinal vein occlusion or tributary retinal vein occlusion. You may have this kind of a pattern again. So always in glaucoma, you have an inter-eye asymmetry. That is a typical of glaucomatous eyes. You can see the butterfly, one half is there, one half is just pale. So this is how the glaucoma eyes will appear. Coming to the next one is something called as purple eyes. What is this purple color means? The purple color means it is the thin atrophic retina. So where all you see this, you can have it in advanced glaucomatous eyes, high myopics, vascular occlusions, or other different kind of optic neuropathies. This is one of the good articles that you can read about optical coherence tomography in neuro-ophthalmology. One of the best given articles. So non-glaucomatous optic neuropathy, you should understand what are the other things that it may have an effect on the GCL so that you are not getting confused with the glaucomatous damages, how it has to be appear. So one is very commonly we see this is the multiple sclerosis. Then you have something called as a microcystic macular changes, optic disc drusen, which we don't see very often. But then the first two things we see that very often. The idiopathic intracranial hypertension, we see papilledema, AAON, CON, all these things we see in our regular practice. So when you have the multiple sclerosis, in the acute phase, you have the axonal flow is blocked. Then the acute phase, the retinal nerve fiber layer has a higher thickness. Once it is about 2 to 3 months time, the acute episode is over, then it will start thinning out. Then the GCL thinning can happen as early as in 2 weeks. The OCT is being used extensively in the developed countries for following up of this multiple sclerosis patient to understand how the disease is progressing. So this is a typical sign of something called as a red circle sign, which we see. We have enough number of patients with us with the red circle sign in OCT, the deviation maps. You see this ganglion cell layer has gone here and showing this typical red circle sign is a multiple sclerosis patient. And what you see here is the overall, if you see the thickness is okay, but typically you see that the temporal loss is there. You see the cupping is fair enough. It is not a very typical of glaucomatous eyes, but this is a typical MS patient. In the minimum rim width, you may not see much of a change on the disc, but you see in the retinal nerve fiber layer thickness, you see the temporal, both the temporal is gone in this. That affects mostly the papillomacular bundle. In a spectralis OCT, you have a program called as a N-site that is usually used for all the neuro-ophthalmology patient. We use that, and you can see that the temporal papillomacular bundle is affected in both eyes. So this is a very typical, that is called as a temporal change is a sign. And you see this is typically symmetrical. In neuro-ophthalmology, most of the times it is very symmetrical presentation. And you see this, the retinal thickness map shows very thinned out retina. It is almost like 50 to 70 micron thickness is lost in these eyes. I'm showing both the right and left eyes. And you see the GCL thickness where I mentioned earlier, you will have donut pattern of the GCL. It is completely gone, but you see the cupping is perfectly there. No problem with the cup, but the GCL map completely gone. We had surprises. Patient came with a headache. And then when we did the OCT, I got really irritated with that patient. I sent the patient for a OCT for some other reason. But then the patient came out with this kind of appearance. And then we diagnosed this patient as what you call, I'm not getting that suddenly. I'll just tell you the information. But this patient also had a MS a long time ago. So the deviation map typically gives you this red circle sign and also see this papillomacular bundle. But in our scenario, what you need to know is these are very typical of toxic optic neuropathies like ethambutol toxicity, which is very commonly seen in our country as we have a highest number of tuberculosis in our country. 16% of the patients with the ethambutol will have the toxicity. Something similar to this we can pick up once you are very careful about doing the OCT. And also the hydroxychloroquine toxicity in many of our the rheumatologists, they give the HCQs more than 200 milligram, then you can start seeing that these patients might have similar kind of an appearance. And also we see the B12 deficiencies, the vitamin B12 or the nutritional deficiencies also will present something similar to this. So usually in a glaucomatous optic neuropathy, always there is an asymmetric presentation. In a non-glaucomatous optic neuropathy, then you will have mostly the symmetrical representation. So what is this? Next is the microcystic macular changes. That is a very unique, which has been recently detected and reported by many people. And it is like 2012, they started seeing these microcystic changes. So what does it mean? There is this is likely that these changes are due to the retrograde axonal degeneration and that loss of retinal Muller cell function. That is how there is a formation of a microcyst in the inner nuclear layer. You can see here, this is the microcyst formation. Once you start seeing in your OCT, you will start appreciating. So that means there is a disease is happening there. So you have to make sure that you treat them properly, but that could happen in many of the patients. It is not only in glaucoma, it could be seen in many of the diseases like hereditary optic atrophy. About 75% of the patients will have these microcystic changes. In comparison to the glaucoma, it is only about 17 to 18% of the patients will have these microcystic macular changes, which we have seen very often in our own patients. So see here, the cup is bigger, but it is not like a glaucomatous cup. But you see the thickness here, more the darker area, that means more the thickness there. And you can see the inner nuclear layer, can see the microcystic changes. Once you see that, then you try to understand that there is something happening over there. Okay, so that's how you pick up the microcystic changes. And you can see that the retinal nerve fiber layer thickness is really depressed in those areas. And you see this, can you see this mark here? There is a thinning happening. In the papillomacular bundle, there is a thinning happening. There's the arrow here. Once you see the blue here, that means the thinning is happening over there. And you can see there is a loss of retinal ganglion cells. So typically you can see there's a pooling here. That means there is a thinning in the GCL area with the papillomacular bundle. But then you see the GCL, the deviation here. But I'll show you something very interesting. You have seen this, the GCL and the papillomacular bundle thinning. But then you see this, the red sign is the increase in the thickness of the INL, in the inner nuclear layer. So that is a very typical sign. That is a microcystic changes happening there. So you have to understand the disease is progressing over there. So I'll just go to the next area. So the optic disc drusen, which is not very commonly seen in our patients, but once you start seeing, then you will identify more of these drusens. There's other thing called as a PHOMS. That is a peripapillary hyperreflective ovoid mass-like structures you see here. So what is the difference between this and this? In the optic disc drusen, there is an intracellular and extracellular deposits of the calcified over time. These are just probably a variant, we don't know, but this is two different things. One, you see in this here, drusen, you have a hyporeflective area, then you have a capsular area like this, there's a thickened area. But in PHOMS, it is like very hyper-reflective area. So that is the difference between PHOMS and the drusen. And we see the drusen with the IR fundus images, something like this. And you can see this, there's areas of hyporeflective and hyperreflective areas in the FAF fundus images. So I will not go much into the drusen, but the drusen again gives you a lot of changes in the retinal nerve fiber layer area. You can see the red areas here, more red areas. And you see the ganglion cell layer again, the thickness of the ganglion cell layer also gets lost in the drusen. When it is progressive, then you can see more and more GCL loss, which can be identified in this. So I'll just go to the next one. I'm sure that it is really tiring, but next one is the anterior ischemic optic neuropathy. When you're looking at the AION, which is again commonly seen in our population, within the first 2 months time, you can see the progressive RNFL thinning. In 2 to 4 months time, optic disc will go for a complete atrophy, and then it stabilizes over a period of 6 months. But what is interesting in the AION is the GCL thickness becomes very less within 2.2 days on an average. That's very interesting to see what happens in the AION diseases. So typically in AION, the rim thickness becomes, initially it will be thicker, and then over a period of time it becomes thinner, and also the RNFL, you can see the typical pattern, the temporal is gone, the inferior temporal is gone in this as well. And this is again a typical pattern of the posterior pole. When you see the ganglion cell layer, you have half of it is lost. Symmetrical half is gone. This is a very typical, but it will not be like this in a glaucoma. Though you see this pattern in glaucoma, but it is half is cut. That's the typical of AION pattern that you must understand. This is not a retinal ganglion, the NFL loss. So very typical of you can see this. So it starts from here, it goes as a horizontal, very typical pattern of AION with the altitudinal field effects. But when you can have something similar to this, when you have the retinal ischemia or arterial or vein occlusions, but once you have the vein occlusions, then you will have the both INL is affected in this, the inner nuclear layer. So that is what will be affected when you have the arterial occlusions. The last one is the compressive optic neuropathy. Wherever you have the compression, then depending upon that, you will see this. This is one of the patients of ours who had 30 years old lady came with a defective vision. So this is what is called as a ENSIGHT program. You see this papillomacular bundle is thinned out, and also the nasal. When you have the bow tie pattern, this is a typical of compressive optic neuropathy. So you'll have typically the bow tie pattern, and then you see this. When the compression is there, then you will have the half cut. You must be remembering the upper half is there and the lower half is gone or partially gone in the glaucoma. But in the compressive optic now, you can see the GCL will be half cut vertical. This is a very typical of compressive optic neuropathy with the visual field showing like this. So this patient had a craniopharyngioma, and this is another patient. I will just, this is an infarct. Why I wanted to show is there is a asymmetrical presentation which can happen in the neurological cases also. This is a cerebral infarct patient which is showing up as a GCL loss. And we have the last one interesting patient which, so when you are looking at this patient, this is a 21 years old patient, came for a routine checkup. Patient had a decent vision and everything is fine. But then what we have found is that you see this GCL thickness is perfectly all right. There is no GCL deviation, but the whole retinal thickness map showed a complete drift in this patient. So I was really not knowing what this is, but then when we saw that the outer nuclear layer has completely gone for thinning. So this is a normal outer nuclear layer, how it will appear, but you see in this patient is completely gone. That's why the whole retinal thickness had a shift. So the reason was the patient had possibly either a pachychloride or a vitamin A deficiency, which is affecting the outer nuclear layer. So this is very interesting. Each layer you go and assess, then you will start understanding that there are so many things which we can pick up. So identifying the patterns in this is important. This is how the glaucomatous eyes will look You have the retinal thickness map, GCL map, the RNFL deviation, and the GCL deviation map. And then this is how it appears in the MSON, or it could be in the toxic optic neuropathies or the nutritional optic neuropathies. Then you have NMOSD. I'm not discussing that here now. Then you have the optic disc drusen. This is how it appears to be, but it could be similar way. It could be appearing in advanced glaucomatous eyes as well. And this is the typical pattern of AON in the posterior pole, the retinal thickness, the GCL map half cut inferiorly. Then you have the compressive optic neuropathies. Also, you can see something similar to this. I really don't know about other OCT machines. I'm just giving you the Zeiss machine here, but I really don't know how to read in this. But in those machines also, you have the GCL map. Try to pick up as much as possible. There's something called as a Pano map in the Zeiss OCT, and you have the Top Gun OCT. I really don't know how to use it, but you can just go back and see in your OCTs. So I would like to sincerely acknowledge two people who helped me to develop this slide deck. Dr. Sweta, she was my fellow, and now she is a glaucoma consultant with us. And Mr. Martin Long, he is one of the guys who really help us in identifying all these patterns in glaucomatous and non-glaucomatous eyes, who is working for Heidelberg Spectralis machine. Thank you all, and for the million cells, for teaching us so much of information, how you can identify the glaucomatous and the non-glaucomatous eyes. I'm sure that this topic is really little bit dry, but then we can really pick up so many diseases, which is really exciting for me at least. I hope it is going to be exciting for you too.
Mind-boggling, Satyan.
Satyan, this is a PhD masterclass. This is a PhD masterclass, and you opened up a new vista totally.
Yeah.
Totally, it's a new ball game, and it's really mind-boggling stuff. And
Yeah. Wonderful, Satyan.
What happens in traumatic optic neuropathy? Done.
Sorry, again, it starts by 6 to 8 weeks. You start seeing the papillomacular bundle area getting up as a damage. And then, of course, you start seeing the GCL map, the thinning out of the GCL. The GCL starts from the temporal and then goes up to the disc and then goes in. That's how it starts. Usually the disc changes will happen a little later, but the GCL comes much earlier. But we don't do much of this OCT and the GCL mapping, sir. But then this is one of the wonderful tools which I feel we all should start using. The patient whom I forgot is the Guillain-Barré syndrome. The patient had 30 years ago. And I saw the patient had 6/6 vision, but the color vision completely lost. She came only for a headache. And then when I did the OCT, the GCL was completely not there. So I was wondering what the patient had. She denied the history. It took about half an hour. And then she brought the whole list of documents. Then we saw that she was treated for a Guillain-Barré. So Guillain-Barré has really completely taken off the GCL.
Amazing.
How much does it cost, Satyan? That package which you said, the glaucoma premium.
No, it is already there. It is already there.
It is there. It is inbuilt.
The basic machine itself.
The Zeiss machine, Cirrus machine, also the GCL mapping can be done?
Yes, sir. Yes, sir. Just go for the Pano map. Just go for the Pano map. But I am not sure. The only disadvantage in others is that it gives you the GCL and IPL together. Other machines. Only the Spectralis gives you the GCL separately and the IPL separately.
Yeah.
But once you see that the whole retinal thickness is affected and you see the GCL is still intact, that means something else is going on there. You have to see the internal inner nuclear layer, the outer nuclear layer, everything you have to see, every layer you see, you can see that and then come to some conclusion. So you can diagnose retinal disorders, vascular disorders, neurological disorders, glaucomatous, everything you can really see. And also, I was really surprised to understand that many of the neurologists in US, they use the OCT for their follow-up of the craniopharyngiomas or meningiomas that they operated, and also for the MS patients follow-up. Instead of doing every time the MRI scans, they go with the OCTs to see how the patient is progressing.
Great. Murali sir wanted to say.
Murali,
I think it's an amazing talk, Satya. I think, very
Thank you.
fantastic
Very
presentation.
nice. Very nice.
Very clear concepts and very clear understanding of the. We literally looked at all of the RGCs and not just glaucoma alone. And I have a few comments and questions regarding our explanation to PGs regarding what is pre-perimetric glaucoma. So basically, in glaucoma, we say that the field defect has to be there, typical defects have to be there in glaucoma. And we all say that the structural tests or structural changes usually precede the functional changes on perimetric. How true is that regards to that? Is it always true that we get structural changes first, or we see it sometimes in the fields also before you see it on structural changes? And with regards to the new revolution in technology such as the spectralis, in which you even have the fixation and the same area being scanned subsequently, which is a great advantage with the spectralis. So how do you position this in picking up the change, and how much of RGC is usually lost before you pick it up on spectralis?
Okay, just coming to the spectralis VCT, the variables, you do it today and then one more scan tomorrow or next visit. The variability is only about 1 micron. The next best VCT gives you the variation between 6 to 8 microns. What I'm talking about is the GCL mapping. The GCL thickness is on an average, it is between 40 to 50 micron thickness. But when you have a variability of about 6 to 8 microns, that means your 20% variability is already there.
Correct.
So it is very difficult to say the progression in these patients. So when you have only 1 micron, then you have something more meaningful to pick up the damages. And also it is not that the same area is scanned in the spectralis. That is not the thing, but all the other machines also come out with the same area can be scanned now. The main thing is the anatomical positioning system where the macula and the optic disc is scanned properly to understand how the raphe is formed. If you're not looking at the raphe, how it is formed, that is the retinal nerve fiber layer coming to the macular area. Once it is not understood by us, then whatever we see is misleading for us. Sometimes we take that as a glaucometer size, and then sometimes we take it as a normal. So that is the problem if you don't do the anatomical positioning system in marking the macula and the disc centration and also the BMO area. That's the importance. So coming back to your question of the pre-perimetric glaucoma, which comes first, I really don't know the answer for that because it is really confusing because once you start seeing the GCL.
How much of RGCs go before you start seeing it on say spectralis, and how much correlating with the field?
At least they say in the studies by Hughley et al. Says about 25 to 30% of the RBC, retinal ganglion cells would have died.
More than that.
Yeah, initially it was about 50%. Then the recent study says that at least by around 30% is the one thing which we can really look at. But the problem is we never do a 10-2 visual fields. We all do only a 24-2 or 30-2 or a dynamic in Octopus. But then when you start looking at the early GCL changes and then you start seeing the central 10 degrees, then you will start picking up the early glaucomatous changes. But we never see the GCL map. We always see only the RNFL or the disc change, which is not a correct method to see because it is always a orthograde. So starting from the temporal RGCs, it goes inferior or superior RNFL, then goes into the optic disc. But what we see is always on the optic disc, or not even optic disc. We see only the RNFL changes. If the disc is small, then again we have problem. If the disc is large, again we have the problem because the RNFL scanning is not done properly. So always look at only the GCL, both superior, inferior, and the temporal part of the GCL carries a lot of weightage. So start seeing from there, then seeing from the disc to this way. That is not the way that we see.
Satyan, will you, whether it will, it's changing your approach to the patient, especially in treatment for that patient? Suppose patient vision is normal, field is normal and unless, of course, suspect or something like that, no? Only with this one will you start treatment or wait. So in
So it
what
depends-
way it's going to change your
Yes,
glaucoma
yes.
practice?
Yes,
Glaucoma
sir. Yes, sir.
practice. Yeah,
Yes,
yeah.
sir. It is very meaningful to do so because earlier we used to say that once you don't see a visual field change, why do you really want to do so? But the problem is when we have the strong family history of somebody has lost vision in the family and this boy is young, why we should allow this boy also to have a visual field damage and then we start treating. It is not the ideal way to go for, because this boy is going to have, say, for example, this boy has only 35 years old, and then we know the life expectancy year on year or every decade it is increasing by at least 5 years. So next 50 years, we need to save his visual fields or the functional vision. So I would definitely look at the GCL map. And of course, we need to see the fundus photography and correlate everything with the visual fields also. But with the introduction of the pattern ERG and the particularly with the photopic negative response from the ERG, we can definitely look at which are all the sick ganglion cells, and then we can definitely treat. This is one area which I wanted to re-emphasize is once you see the sick cells, once you start treating these patients, it can reverse the disease before the cells die. That is the advantage of having the pattern ERG in identifying the early disease. So the disease can be reversed. But once whatever we see in the visual fields and in the VOCT are the dead cells. We are going to see only the dead cells in this. So a combination of pattern ERG and the VOCT in the initial phase of the disease, once you start treating this, at least we can make sure the functional loss is not there in the later part of the life, because we don't know how these patients will respond to the management. Now he is 35, 40 years. By 60, 70 years, we really don't know how these patients will respond to the medication. So earlier concept of understanding only, okay, there is no damage, why do you want to treat? We really can't say anymore because we really can't understand how these patients, the compliance is going to be, the effectiveness of the management is going to be, we really don't know. We don't have to really wait for the functional damage to occur and then we start treating. I think it is the other way around, we can go for it.
Fantastic. Very good concept.
Superb. One or two questions we have had. The questions are a bit slow, but they have come.
RK sir,
how long it will take such a patient to structural damage is there, no?
Yes, sir.
No? How far it will take for the functional deficit to occur, especially in the form of visual field. It's not an overnight change, no?
It is not an overnight change, sir, but the
Yeah.
problem in identifying the functional change has again a very high variability depending upon the patient understanding of how he needs to do the visual fields. So that is the reason why the pattern ERG or the PHNR really helps us objectively understanding how the functionality of this patient is. So definitely, yes, doing the visual fields in the moderate to severe disease, the visual fields is the best way to go. But when you want to look at the electrophysiological testing, glaucoma suspects, ocular hypertensives, early glaucomas, these are the three areas where the pattern ERG really helps us to understand how do you really want to proceed with the treatment.
So there's
No
something
visual
called as
fields.
the, something called as a tipping point. I think that's what Dr. RK is referring to.
Yeah.
The tipping point is the point at which the RGC loss, that is the structural loss, changes into a functional loss, which is detected on standard perimetry.
It's very difficult to understand, Molly, because each patient is different. We can't really say
So
when it
the,
really comes in.
machines are different. The spectral OCTs are different. The spectralis is different from the Zeiss OCT. So given the spectral OCT of the Zeiss, a paper has been published which says that about 17% of RGC is lost before it is picked up on spectral OCT and starts showing changes in the standard 24-2 kind of perimetry. Now, of course, we have spectralis and we also have the 24-2C. The 24-2C incorporates points of the 10-2 into the 24-degree field. So things are going on changing. So the so-called pre-perimetric glaucoma definition also keeps changing.
Yes.
So I think
with the newer strategies in the perimetries and the betterment of the OCTs, but what we need to know is in isolation and when we don't know what is what, then things are different. Just doing OCT and then picking up something red sign is not the ideal way to go, but you need to understand in depth of what the machine gives you the details. If you can't understand what is the machine gives you, then the whole thing is a waste.
Is the normative data there, boss? Normative for all these layers. You are looking at color codes of these layers, which means the machine is coloring them with some normative data. Do they have for each layer?
It is not the normative data which we are really interested in. But nowadays it is a big talk about keep talking about all the normative data. But what is that we are looking at is what is currently there and how much it is progressing. That is the change we are looking at. What is for us interesting is how much is the change which is happening today and by tomorrow or by next month. That is what we are really interested to. But this is the big cry about keep on talking about the normative data, which I feel is important. It is not that totally we can negate, but then we need to understand what is the current picture and what is the next picture shows. What is the variance it shows? That is what we are really interested in.
And you can compare with the other eye. Other eye, same layers. Yeah.
Yes.
And should the case have a diabetic maculopathy or something of that kind, things will change, no? Or is that layers unique? Is the GCL layer still unaffected by a maculopathy?
Yeah, that is the reason I told you in isolation, if you really can't understand and read, then you will be in mess. You have to really understand each layer, why the thickness, the microcystic changes can be present in the glaucomatous or non-glaucomatous, and of course it can be present in the retinal, other vein occlusions or the diabetic retinopathies, everything. But you need to really correlate. Otherwise, you're going to make it as a mess. You are going to diagnose every patient having something else or the other. But you need to have a thorough knowledge. But this class gives you an overall idea. But there is so much to be evaluated. Because I didn't know that we were wondering why that retina shows so much of a thinning. GCL was normal. Then we could pick up when we went into the bottom of the layers. Then we could identify the outer nuclear layer was completely gone, which is more of a vitamin A deficiency in a 20 months. We never even suspected it.
Great.
Thank you very much, Satyan. Very nice.
Excellent.
Because we have spectralists, but I never looked at all these.
I have two questions, Satyan.
Yeah.
Yes,
MR sir has a couple of
Yeah,
questions.
you are talking about a patient with a cerebral infarct
Yes, sir.
showing some outer nuclear
Yes,
thinning.
sir. Yes, sir. So cerebral infarct.
Is it a coincidental one or it is related to that?
No, sir. It is we have done it purposefully. We have done it purposefully. RK sir, unga mic mattum.
RK sir, the mute point.
Okay.
Yeah, sorry, sir.
Yes,
The infarct will typically give you the GCL irregular appearance of the GCL, sir. But it may be vertical appearance, but it will be little irregular. Something similar to the glaucoma. But in glaucoma, it is always a horizontal. But in a cerebral infarct, it is vertical, but it is irregular. But the areas of thinning is again irregular in a GCL map in an infarct. So we can definitely identify the infarct versus the compressive optic lesions separately. Again, it is vertical, but more of a symmetrical in compressive optic nerve head lesions, optic neuropathies. But in infarcts, it is little irregular because the infarct may be more in one area, less in the other area. So depending upon that, it may be little variability will be there. But it will be always be bilateral.
Yeah.
Another question I want to ask all the panelists is that we see a perfectly normal disc, okay? But when you do a OCT, it shows red. There is RNFL thinning is there. What is the reason for that?
Sir, you are talking about the RNFL or the disc?
Perfectly normal disc.
Okay, sir. The RNFL thinning, as I told you, it can be of many reasons, sir. That's why I wanted to show you that so many variables. But what we keep thinking is always it is glaucoma. If it is red and then we discard it as, okay, the disc appears to be normal. This is nothing related to that. But that is the exact reason why I wanted to do the presentation, that please look at the GCL map, RNFL map, a complete spectrum. Other one which I would like to emphasize, I'm not sure how much it can be useful to all of you. Please connect your systems through the LAN and to your desktops in your OPD. If you have not done that, you cannot ask 10 different printouts or 15 different printouts for every case to be seen. And it is not good to see like that, because whatever you have a printout, you cannot magnify, you cannot minimize it. And as we are all aged, we are not able to see the numbers also in that. But once you have it in your desktop connected, all the machines give you the connectivity in your desktop. But it is the licensing, at least 3 licenses the Spectralis gives you free, but other machines you can ask for. Once you have connected that, then you run through each location, disk, RNFL, GCL, everything you can run through and then identify what the patient has. Otherwise, it is going to be again just looking at the fundus photo in a sheet of paper color print. I feel it is not at all useful. And we are moving towards something much better than what we had earlier. I think we all have to move at some point in time, which is not very difficult. It is not going to cost you anything. It is just take a wire, connect it to your LAN connectivity, and then access it in your system. Just ask your company guys to just connect and give you.
We are doing that. That's not a problem. But if it shows consistently red, you have to do a GCL.
Absolutely, sir.
That's what is.
You need to understand the pattern of RNFL. Is it a temporal, or is it an inferior, or is it a papillomacular bundle completely gone? Then you will pick up all the diseases.
I think your point is well taken, Satya. I think it's fantastic because recently I have been seeing the last few months. This is besides glaucoma. I know it's an ARC on glaucoma, but last few months I have been seeing in my ophthalmic practice about 5 or 6 patients with ethambutol toxicity, which has been missed by the physicians purely because they only look at the vision. Some of them only look at the reading near vision and then say, is it optic neuritis, is it the ethambutol toxicity or not? But this can be easily picked up on the GCC and the GCL and the OCT scan, which is it. So I've told, I believe the tuberculosis program has changed the ethambutol dosage, and they have increased the dosage and the duration for at a higher dose. So therefore, the screening for ethambutol toxicity is now becoming relevant. There's an article in the IGO recently about ethambutol toxicity and the need for ophthalmologists to pick up earlier. So this is where I think this kind of technology would actually help us pick it up, because the change due to ethambutol toxicity is not reversible. You have to stop it at an earlier stage and you cannot reverse it. So identifying early stage.
Murli, that is an interesting area, Murli. I'm just sorry to interrupt you in this.
Yeah.
We had one lady who had come with a similar kind of ethambutol toxicity where the GCL is gone. But when we started treating her with a vitamin B12 deficiency, you see these ethambutol patients, they will definitely be associated with the B12 deficiencies. Yes. The moment we started treating her from 636, it has come to 69. So it is very interesting to see. And also the patient who had the disc was completely normal, the cup was normal, but then there was a huge inferior RNFL loss. We were clueless, but then we could identify that as mostly the AYN pattern. So it is very, very typical, that half cut. It's very typical of AYN, which we really missed out. So looking at the patterns, we start looking at the patterns, then we start appreciating more diseases, what the disease is going on in the patient.
Fascinating.
Yeah, it's absolutely true, especially in ethambutol toxicity. What normally we do in OP, they will do visual fields, color vision, and fundus, etc. Everything is normal.
Normal.
We will send, but then after 6 months they will come with the defective vision.
Yeah.
So HCQ and ethambutol.
Yeah, same thing. Yeah.
Even HCQ also. HCQ.
Yes, yeah.
So we have.
But these are the vulnerable cases. All these cases they should have. Whenever possible, or we have definitely.
I think OCT is the way to go, sir. OCT.
Absolutely.
Yeah, definitely. Yeah.
You just start seeing the HCQ and the reverse pit.
Yes.
Reverse optic pit. That is a very typical of HCQ toxicity, which we started seeing more numbers, sir.
Very good.
And also the other interesting area which I would request you to see is we know that we have so many alcohol patients. I'm not blaming the government or anybody else, but you start seeing the typical toxic optic neuropathies in most of our alcohol patients. The bundle is gone, the GCL is gone with the red circle sign. You start seeing that very often, especially most of the patients will have the mix, that is a local with the Pattasarayam, with the government circle.
Yeah.
And many deny, but once you start seeing that, that is very interesting to see also. So thank you so much, sir.
The highest, I think they had 500 crore. Tasmac was 500 crore.
Couple of days, yeah.
We'll start seeing more patients next week.
Yeah.
But
Yeah.
surprisingly, Murli, I also will. In the past 1 year, I don't know, for some reason, I'm not sure. I've seen more ethambutol toxicity in the past 1 year.
The dosage has increased, sir.
Because of that only, 800 milligram they have made it.
They've changed the pattern of prescription and they've changed the dosage.
That's correct.
What was MDR TB has now become XDR TB, sir. Multi-drug resistance has gone to extreme drug resistance, and they are pushing doses very high. And that is what we are
more
seeing.
of it in the future, sir.
Yeah, we'll see more of TB in the future, probably. And
But
now to MR sir for his closing remarks before I say the whole thing.
No, it's really, I would say, a very, very enlightening masterclass. And it is, one was, the Dr. Ramakrishnan was really a basic, and sound basics, you should need to have a partial thickness filter, and the basics of glaucoma surgery, which is again very, very important for all of us, not only for the practicing doctors, but also for the residents, very important, which is beautifully covered by Dr. Ramakrishnan. And of course, Dr. Satyan took us to a different level altogether. So for a while, I was thinking whether Satyan is in this planet or some other planet. And he took us to the future of.
Definitely.
It's been a really eye-opener for all of us. Looking at the GCL and so many other factors which will be able to pick up the glaucoma, or even not only glaucoma, so many other diseases much earlier than normal. And if you're able to pick it up much earlier, then the treatment modalities also will be more effective. Satyan, really fantastic.
Thank you so much.
And also the panelist, Dr. Murli Erika, you are a wealth of wisdom and knowledge, and I have seen you live surgery and your comments in really fantastic, Murli. Really, thanks a lot for being here. And Rajshekhar, over to thanks.
Mohan sir and all the other panelists, I really thankful to you for giving me this opportunity to talk on this particular topic, sir. Thank you so much.
You're welcome.
Can't believe it's past 2 hours and still people are listening.
They are listening in multitudes was, and they'll keep seeing it again and again, revisiting it in the social media. It is being posted in the YouTube forever. So in the Facebook and for YouTube, they can see. In fact, what I wanted to share, is that I am really awestruck and not to know about what to get awestruck about. One, about that OCT, the wonderful tool that OCT has become. It has become so very translational and transformational. It has just rewritten. It is rewritten how ophthalmology can be. And I think in our lifetimes, we will not see the last word. It will go on like this forever. And probably this OCT tool had been wonderfully made as a banquet to us by Satyan. I wish him into his, if he is working into it, we can see his passion in his eyes when he speaks about each of the things. We wish him all the very best to bring it into publications and bring this into the world. And the wisdom of RK sir, I'm really amazed how somebody can, some musical summary that being on earth and sharing his wisdom of 30 plus years of glaucoma management to the students in their way they will understand and they will engage with, and they will use it in their day-to-day lives. If this ARC session is not marvelous, what else is? I think we have had an international level ARC session today, and I really thank the Tamil Nadu Ophthalmic Association, President Dr. Mohan Rajan, Secretary Dr. Madhavan, Treasurer Dr. Lohanathan, President-elect Dr. Ramakrishnan sir, and Vice President Dr. Nirmal Frederick, for giving us this wonderful vehicle through which few minds can sit together and share and have so much of knowledge communicated between each of us. And I'll also thank the master instructor, Dr. Satyan, to make who lived up to his expectation and raised the tab of this ARC masterclass to the next level. I think the next masterclass will have it still more tougher to raise up to this level of expectation. And I singularly thank Dr. Murli Erika, because Every word sir chooses. I am amazed at Murli Ariga because he is a person who measures his words. Even I think the modulation of his words he measures. And every word he has spoken has
No,
added so much of
Murli-
insight into
Murli gives
whatever we have shared.
No, Murli.
Yeah,
What
sir.
I like
Yes,
about
sir.
Murli, Rajshekar,
Yeah, yeah.
is the practical.
Exactly. Not even a
Practical
single comma or full stop, not
Right.
in its place, not in its
He loses
necessary
it.
place.
Yeah, fantastic.
Yeah, that. So probably Murli sir will be the next master instructor when we go again to the glaucoma cycle. We'll have to finish all the specialities. And with that, loud cheers and loud thanks to all the good minds and young hearts who have been listening to us all through this time and that shared a lot of questions with us in the chat box. And this is a wonderful masterclass. The next masterclass, this masterclass just switched from Friday to Sunday for Pongal. The next masterclass will be the second Friday of February. Until then, see you.
Thank you so
Good
much.
night.
And one
Thank
last
you.
thing,
Good
sorry
night.
to RK sir,
Yeah,
holding your sleep.
தூக்கம் வருது தூக்கம் வருது நல்லாவே
Mark million cells.
Million cells, sir. Million cells.
but very nice.
We have to thank Milmet people. Milmet for
Sure, sir.
sponsoring, powering this masterclass.
Yeah.
And Roshni, thanks a lot. Raju, Hitendra, all the people from Milmet. Don't forget Megabrom and Glow Eye.
Thank you.
Thank you.
Thank you so
Good
far.
night.
Thank you.
Good night.
Thank you.
Thank you, sir.
Bye.
So from here, now I'm ending the meeting. Thank you.
Yeah, thank you.